Hey everyone, it's Jamie.
David,
and Catherine, and we are going to talk about strokes.
A stroke, otherwise known as a CVA or a cerebrovascular accident, is when there is insufficient blood flow to the brain due to ischemia or hemorrhaging.
strokes are broken down into two types, ischemic and hemorrhagic, which are further broken down into thrombotic ischemic, embolic ischemic, intracerebral hemorrhagic, and subarachnoid hemorrhagic.
Let's start by talking about ischemic strokes, which are the main cause of strokes. In an ischemic stroke, there is inadequate blood flow to the brain because of partial or complete arterial occlusion or blockage of an artery.
A thrombotic ischemic stroke occurs when a clot develops because of an injury to the wall of a blood vessel. The clot then gets lodged in with the plaque and has the potential to fully cut off the blood supply of that artery, causing infarction or tissue death.
People who have a history of a prior stroke or a transient ischemic attack, high cholesterol, atherosclerosis, hypertension, or diabetes are at high risk for a thrombotic stroke.
It has also been found that having a history of acute coronary syndrome or ACS and a prior stroke or transient ischemic attack often precede a thrombotic stroke.
Now, let's talk about embolic strokes. These originate within the heart and take place when a plaque breaks off from the endocardium and travels up to the brain. The plaque then lodges where the vessel bifurcates or narrows. Once occluded, the area where the vessel is involved begins to infarct and swelling develops.
Comorbidities that increase risk of an embolic stroke are heart conditions such as atrial fibrillation and myocardial infarction and long bone fractures. In atrial fibrillation and myocardial infarction, blood within the heart is not moving and can clump together to form a clot that can travel to the brain. In long bone fractures, fat and air are released, which can result in an embolus that can travel to the brain.
In both cases, embolic and hemorrhagic strokes, the onset is rapid, but the difference is that embolic strokes are a vessel is occluded, whereas a hemorrhagic stroke, a vessel is ruptured.
Intracerebral hemorrhage occurs when a vessel in the brain ruptures and starts to bleed. As blood fills within the brain, blood clots form in an attempt to close off the leak, further increasing intracranial pressure, leading to ischemia and infarction.
In subarachnoid hemorrhage, bleeding occurs between the arachnoid and pia mater membranes by a rupture normally caused by a cerebral aneurysm commonly found in something called a circle of Willis. While a majority of the aneurysms do not rupture, the ones that do are saccular or sac-like, otherwise known as grape-shaped.
There are ways to assist in preventing a stroke, such as drug therapy, surgical therapy, and proper management of pre-existing conditions like diabetes, hypertension, and underlying heart problems. It is important that we as nurses help patients feel that they are able to have autonomy over their own health. We can help them with this by helping control their comorbidities and educating them.
Alcohol intake can also be limited, and as always, stop smoking.
If a patient has a history of atrial fibrillation, therapy with platelet inhibitors and anticoagulation therapy will be started.
Some examples of preventative surgical therapy include transluminal angioplasty, stenting of a carotid artery, and carotid endarterectomy.
All right, now that we know all of this information, how do we treat a stroke?
First, we have to figure out if in fact what the patient had was a stroke and not another type of brain lesion. And if in fact it was a stroke, what type of stroke it was.
Signs and symptoms of a stroke include facial droop, sudden numbness or weakness of the face, arm, or leg, especially on one side of the body, sudden confusion, difficulty speaking, or difficulty understanding speech, change in vision, sudden trouble walking, dizziness, loss of balance or lack of coordination, and sudden severe headache with no known cause.
We figure out if the patient had a stroke and what type by imaging the brain via CT or MRI. This serves as the main diagnostic tool in telling us if the stroke is ischemic or hemorrhagic in nature.
If ischemic, cardiac imaging might be recommended because remember, atrial fibrillation is a risk factor for stroke because it can form clots that the heart can more or less spit out.
If hemorrhagic, more testing will be done by using a cerebral angiography or a transcranial Doppler ultrasound. This is done in order to see if the hemorrhage is or is not subarachnoid.
So, once the type has been determined, medical management will begin, which will include acute care of the patient's condition, drug therapy, and potential surgical therapy.
Acute care includes maintaining the patient's airway and preserving life, fluid therapy to ensure adequate hydration and promote perfusion, treatment of any cerebral edema and prevention of further brain damage, preventing any secondary injury and reducing disability.
Drug therapy differs depending on the type of CVA. If the stroke is ischemic and diagnosed within 3 hours of symptoms starting, a drug called intravenous tissue plasminogen activator, or TPA, can be started. Fun fact, according to the article written by Sharma, TPA is the only approved drug treatment in the USA for ischemic stroke.
The purpose of TPA is to recannulize the blocked artery, or basically make it patent again. But naturally, there are contraindications for TPA use, and include a recent history of GI bleeding, a recent stroke, recent head trauma, recent major surgery, or active internal bleeding.
Something else to consider with the administration of TPA is the patient's age. Safety is always a factor, especially as patients get older. With the elderly population, even though TPA will still work to bust that clot, your elderly client might also ultimately have a poor functional outcome in the end. Strokes account for an immense amount of disability and death that specifically affects those who are 65 years or older.
While TPA is effective, it has a short therapeutic window. Remember, it can only be used as long as the symptoms are caught within 3 hours of them starting. Furthermore, although effective, TPA also has low recanalization rates and only shows modest benefits. This is why alternative approaches have been sought after.
Other recommendations for ischemic stroke treatment are endovascular thrombectomy and endovascular clot retrieval. It has been found that endovascular thrombectomy has the potential for successful recannulization in 79% of patients, and 48% of patients are able to be functionally independent at 90 days. That's a big deal.
In terms of acutely managing a hemorrhagic stroke, the main drug therapy will be geared towards managing the patient's hypertension. Surgical therapy may also be indicated as an option, and there are multiple options. Surgical decompression, if indicated, clipping or coiling of an aneurysm, immediately removing aneurysm-induced hematomas greater than 3 centimeters, immediately removing cerebellar hematomas, again, greater than 3 centimeters, surgical resection or radiosurgery of arteriovenous malformation, or insertion of a ventriculostomy for cerebrospinal fluid drainage.
So great, but what can we as nurses do for our stroke patients? So much, and it starts with what we've learned. ADPI.
We start with the primary assessment that focuses on the patient's respiratory, cardiac, and neurologic function. We also collect subjective and objective data, as well as a history and physical. We then diagnose, plan, implement, and evaluate the patient.
Nursing diagnosis and planning helps determine the problem the patient is facing and develops goals with the assistance of the patient and his or her family or caregiver. It's important to involve the patient in his or her care and goal implementation because it gives them feelings of independence and autonomy.
Different nursing diagnoses for stroke include ineffective cerebral tissue perfusion related to clot, emboli, or hemorrhage from cerebrovascular, impaired physical mobility related to loss of balance and coordination, impaired verbal communication related to pressure damage, decreased circulation to the brain in speech center informational sources, ineffective coping related to disability, self-care deficit related to decreased strength and endurance or paralysis, risk for impaired swallowing related to neuromuscular dysfunction, and anxiety related to situational crisis, change in physical or emotional condition, and those are just to name a few.
Implementation can include assessment of respiratory status, continued neurological assessments, monitoring vital signs, monitoring cardiac strips, regulating IV fluids, and listening to lung sounds, as well as implementing health promotion towards a healthier lifestyle.
We want to continuously assess the respiratory status and monitor cardiac strips to make sure there is central perfusion. With no airway, there is no patient. And without a proper heart rhythm, the patient is also in danger of a worsening condition. With the continued neurological assessments, we are assessing for improving or worsening cerebral perfusion. Furthermore, we want to monitor vital signs to ensure that the patient is either remaining stable or hopefully improving, and to make sure that the patient is not worsening.
A decreased level of consciousness and worsening vital signs are often the first clue to a patient's deterioration. By tracking this, we as nurses can be sure to spot signs of deterioration quickly, and this allows for us to quickly treat the patient or ask for the necessary help.
Furthermore, we want to listen to the lungs as we regulate IV fluids to make sure the patient is not experiencing fluid volume overload. We will also check for swelling to assess for this. And as always, health promotion will be beneficial for the patient long term and also aid them in how they can not only move forward for the future, but prevent further and future health complications.
Upon evaluation, we will do a secondary assessment that includes a comprehensive neurologic examination to further examine the patient's level of consciousness.
And as always, do not forget to document. This will help us as nurses see trends and recognize abnormalities that need to be reported and acted on immediately.
So what happens after the stroke? We enter the recovery and rehabilitation phase with the patient. During this phase, it is important to allow the patient to have a sense of independence, but it is also important that we help the patient recover practically and realistically with achievable goals.
We have to consider that the life of the person who had the stroke is not going to be the same. Their ability to perceive and process information will likely alter their ability to perform activities of daily living, in addition to the physical effects that a stroke can have.
During the transition phase of going from the hospital to rehab and onto long-term care and home care, we as nurses have the important role of performing continued nursing assessments and interventions. These interventions and assessments need to be adapted as necessary with the patient's level of care.
In summary, there are a variety of CVAs, each with their own pathophysiology. Knowing the anatomy and physiology of the brain and heart helps us understand the source of a CVA and therefore helps us determine its treatment.
As nurses, we will help prevent a secondary injury and provide adequate interventions to ensure the best outcome for the patient's current health status and his or her future recovery.
As nurses, we not only aid in healing the patient's physical status, but also his or her emotional and spiritual well-being through holistic care. With the patient's overall well-being as the priority, we aid in their likelihood of recovering to their fullest capacity.